Hello, and welcome to the June video for the Journal of Vascular Surgery. The first paper, by Kim and co-authors from the Vascular Low Frequency Consortium, which includes 60 institutions who collaborate on clinical research using a standardized data collection system, proposed two new preoperative parameters that can be used to assess the risk of nerve injury and bleeding during resection of carotid body tumors. They found that the distance from the base of the skull and the size or volume of the tumor to a Chamberlain classification significantly increases the prediction of nerve injury and bleeding above the Chamberlain classification when used alone. This study suggests that it's important to use Chamberlain to determine the encasement of the internal carotid artery and the need for carotid reconstruction. But these two new parameters, distance from the base of the skull and tumor volume, provide additional information that can be used for preoperative counseling, operative planning, and operative technique. They may also aid in the decision about whether to embolize the tumor preoperatively. The editor's choice and CME paper, which is published by Davis and colleagues from the state of Michigan. It evaluated surgical site infection in patients undergoing lower extremity bypass. They identified predictors of SSI using the Michigan statewide cardiovascular consortium of 35 hospitals between 2012 and 2015. In 3,000 patients undergoing 700 fem-fem, 1,400 fem-pop, and 900 distal bypasses, SSI was diagnosed in 11%. Major predictors of surgical site infection included renal failure requiring dialysis with an odds ratio of 4.4 and hypertension with an odds ratio of 4.3, as well as a BMI greater than 25 and a procedural time greater than 240 minutes. And hospitals with less than 500 beds and teaching hospitals as well. Surgical site infection was associated with an increased risk of major amputation and surgical reoperation. The authors conclude that several patient, operative, and hospital risk factors increase the risk of a surgical site infection and major amputation. They recommend targeted improvement in these areas to reduce SSIs and improve outcomes. The next paper from Hicks and co-authors, who have participated in the VQI database, examined the outcome of patients who undergo EVAR, endovascular repair of aortic aneurysms, and then have variable follow-up, ranging from regular office appointments to phone follow-up to being lost to follow-up. The Society for Vascular Surgery EVAR guidelines recommend a CTA at 1 month and 1 year post-procedure. So only patients who had office follow-up could receive all components of routine follow-up. Over a 12-year period, patients who underwent EVAR had their method of long-term follow-up stratified, and mortality was captured by the Social Security Death Index. During the study period, 11,000 patients underwent elective EVAR, and 80% had in-person follow-up, while 10% had a phone follow-up and 10% were lost to follow-up. Those lost to follow-up had larger aneurysms, more comorbidities, and worse functional status before surgery, as well as greater intraoperative contrast volume, blood transfusion, and use of pressors, as well as more postoperative complications. They were also more likely to be discharged to a SNF, or skilled nursing facility. 5-year survival was 70% higher in those who had in-person follow-up. The authors therefore recommend that surgeons should stress the importance of office-based follow-up after EVAR and the importance of post-procedure imaging, particularly in those patients with a poor baseline health and large aneurysms who often undergo more complicated procedures. The final paper is by Farber and co-authors who participated in the Bolton Relay Phase 2 clinical study, which was an open-label, non-randomized, prospective, multi-center U.S. investigational device exemption trial of 133 patients who were treated with a relay stent graft and a comparison with 60 surgical controls. Stent grafts were successfully deployed in 129 of 133 patients, and at 30 days, a lower mortality was observed in the TVAR arm, that is 5.3% versus 10% with open surgery. TVAR was associated with a significantly lower rate of major adverse events, primarily respiratory failure and procedural bleeding. Freedom from aneurysm-related mortality through 5 years was similar at 91% for TVAR and 89% for the surgical arm. 6 TVAR patients, that is 4.5%, experienced endoleaks, and secondary procedures were performed in 7.5% to repair or correct the endoleak, as well as 1 surgical conversion. Endograft migration occurred in 3 patients, and wire-form fractures were found in 2 patients. The aneurysm sac size decreased or remained stable in 85% over a 5-year follow-up. There were no thoracic aneurysm ruptures or endograft occlusions. The data from the Relay TVAR clinical trial demonstrates safety and efficacy of the Relay device compared with surgical controls, with a low rate of device-related complications through 5 years. We hope you enjoy the June issue of the Journal of Vascular Surgery and commend these papers to you, as well as many others in the Journal of Vascular Surgery.